So I'll be starting in brief about management of sixth and fourth nerve. So we start with the sixth nerve. The symptoms of sixth nerve palsy would be a horizontal diplopia, which is worsening towards the affected side, a phase turn, a major dysotropia, which is concomitant and greater in the field of action of muscle. Now, this is a case of acute onset post-traumatic sixth nerve palsy. All that is required here is just to closely observe this patient till the time the patient recovers fully. This is another case of sixth nerve palsy where the patient presents to us with sudden onset of double vision and he has mild headache on and off with occasional vomiting. There is no other neurological illness and we can see there is a mild limitation of abduction on bilateral sides. So probably it's a case of bilateral sixth nerve paresis, which is partial sixth nerve palsy. So on examination, everything was fine. Anti-segment was absolutely normal, but the fundus showed a florid papilledema and a neuroimaging showed a large space-occupying lesion. So it is very important to understand that sixth nerves could be a false localizing sign. So before jumping for management, we should at least evaluate them, have a good look at the fundus. So a dilated fundus evaluation is must in all cases of sixth nerve that present to us as an acquired case. Now, management options in the acute phase would be occlusion, prisms, and Botox. And 6 months later, we can think about surgical management when the stability of alignment is there for at least 6 months. Now, surgical intervention. For partial sixth nerves, we had options of MR recession, LR resection, performing an RNR procedure, and RNR can be combined with contralateral medial rectus recessions. Now, this is a case of left eye post-orbitotomy sixth nerve palsy. We can see a large scar here, which is after the orbitotomy. And she underwent sixth nerve RNR procedure for the left eye, and this is how the pre and post surgical alignment are. She has a pretty good results. This is pre and the post photograph. Now, this is another case for total sixth nerve palsy. We have options of partial vertical recti transposition with MR weakening or full tendon transposition to the lateral rectus with MR weakening. And now we have rectus muscle reunion procedures or shifting of recti muscle to the lateral rectus with MR weakening procedures. Now, there are various procedures like Hammersheen, O'Connor, Carlson and Jampolsky's, Jensen's muscle reunion procedure, Kushner's modification of Jensen's procedure. Now, all these were fraught with problems of strangulations of vessels and possibility of anti-segment ischemia. So then we have these VRTs, which were proposed by Rosenbaum, and then we had these Foster's augmentation suture being added to the VRTs so that we could augment the effect of transposition. And then lately we have this Nishida's procedure where the muscle is actually not split, but just shifted towards the side of lateral rectus. The superior and the inferior rectus, both of them are shifted towards the lateral rectus. In the original procedure, they were shifted, they were split, but later on it was decided not to, later it was proposed not to split the muscle. So they are shifted to approximately 8 to 10 millimeters from the limbus, midway between the superior and the lateral rectus, and both of them are just abutting the middle of the lateral rectus. Now, this can be added with an adjustable medial rectus so that we can further do adjustments in case of over and under corrections as done by Sir. And this is a case of left post-traumatic sixth nerve palsy. So this patient undergoes large recession of medial rectus along with half-width transposition of superior and inferior rectus along with the Foster's augmentation suture. And this is the pre and the post surgical alignment. Another case, history of road traffic accident 2 to 3 years back, diplopia and primary gaze, and a phase turn to left. So this is a case of right post-traumatic sixth nerve palsy. As we can see in the line, the right eye is not able to cross the midline. So this patient undergoes right MR recession, which is adjustable along with the superior rectus transposition. So we can see there is slight amount of abduction, which has come as I has slightly started moving in the abduction passing the midline. This is another case of post-viral sixth nerve palsy. Again, the left eye is not crossing at all, not moving at all. And this patient undergoes a large MR recession along with superior rectus transposition to lateral rectus. This is this 5 weeks post-surgery. We can see a good alignment here. Botox can also be an option to manage the acute phases. This is a case of left eye sixth nerve palsy where Botox has been given. It's a temporizing measure where we will try to prevent the contracture of medial rectus and let us so that the recovery of lateral rectus takes place for some time. Now, if in children there is no signs of neurological illness, we can observe these cases at 2-weekly interval till the time full recovery occurs. But if it is more than persistent for 3 months, then a neurological evaluation is a must. For young adults between 15 to 40 years, we should look for the risk factors. For patients who are more than 40 years of age, rule out diabetes, hypertension, GCA in little older patients, look for vasculopathies because of diabetes or hypertension. And all the patients with increasing esotropia, developing neurological signs, a detailed evaluation is a must in all these cases. Now we move on to fourth nerve palsy. This is one of the most common nerve palsies which is seen, usually congenital, post-traumatic, viral, and ischemic. It usually presents as head tilt for the congenital cases and asthenopia, vertical strabismus, and diplopia more so in acquired cases. Asthenopia could be seen both in the acquired as well as congenital cases. It is not a sign of raised ICT as it is not a pseudo-localizing sign, but it may be associated with diabetes and hypertension. Now, this is the Knapp's classification, which I had tried to modify, I tried to kind of tabularize. So Knapp's divided various types of fourth nerve palsies from type 1 to type 7. The commonest ones seen are type 1 and type 2, and it is based upon the abnormality which we can see. So with respect to the right eye, if you talk about type 1, there is overaction of antagonist the only abnormality, that is the maximum deviation seen in the levo elevation. What is required is right inferior oblique recession. In type 2, there will be greater deviation in the field of superior oblique, that is marked superior oblique underaction, that is levo depression with respect to the right eye. Then superior oblique tuck or inferior rectus recession of the left eye, or a modified Heredato can be done. Rarely we can have bilateral superior oblique palsies where there would be a V pattern and a torsion of more than 10 degrees, where a bilateral inferior oblique and modified Heredato can be done. Now, if the deviation is in the full field of superior oblique, inferior oblique, then the deviation will be maximum in all the lever positions with respect to the right eye. And if the hypertropia is less than 15%, 25% diopters, inferior oblique recession is required. If the hypertropia is more than 25% diopters, inferior oblique recession plus a tuck can be required. So this is in brief what we can talk about management based upon the Knapp's classification. So always suspect a bilateral fourth nerve palsy when there is a concussion or closed globe injury. There is a V pattern along with these fourth nerve palsy, a chin down posture which can again because of V pattern, alternating hypertropia in the alternate head tilt test. There is an objective torsion of more than 10 degrees and patient complaints of subjective torsion. So we should always look for bilateral sixth nerve palsy in these cases. Now, management options for congenital cases, we have to correct the head turn, so we have to plan for surgery. For acquired cases, during the acute phases, you have to plan for occlusion. Botox may not be a very good choice here, and 6 months later, we can plan for surgery in acquired cases. A brief about Park's 3 steps test. Now, this is a patient of left superior oblique palsy. Here we can see there's a minimal L over R in the primary position. So looking at this, either it is an underaction of left superior oblique or left inferior rectus, or it is an underaction of superior rectus or inferior oblique of the right eye. So as it is the left eye being involved, so these 4 muscles are in question. Now we see that the hypertropia increases in dextroversion. So the muscles left here are the right superior rectus or left superior oblique. And then when we do a head tilt, the maximum deviation is seen in the right head tilt. So it's a case of left superior oblique palsy. And hence this is how we decide on the Park's 3-step test. Now this is a case of left superior oblique palsy presenting with a head tilt towards the right side since the early childhood. And we can clearly see there is a small amount of L over R, but it increases on the dextroversion and definitely much more on dextro elevation. There is some amount of superior oblique underaction, but not much great as compared to this on the dextro elevation. So this is the Park's 3-step test. We can see there's mild amount of hypertropia, which increases on dextroversion. And on a head tilt, we can see there is significant L over R. So what we do here is a left modified Elliott and Rankine's procedure, which is anterior positioning with recession. And this is the post-surgical photographs where we can see that the patient is pretty well aligned and the inferior oblique overaction is gone. And this is the head tilt test post-surgery where we can see again the alignment is good. And this is the photograph showing you reduction in the torsion after the surgery. Now this is another patient of left sixth nerve palsy where we can see there's a gross hypertropia in the primary case and the maximum underaction is in the field of superior oblique. So this patient is planned for superior oblique tuck, and post tuck we can see there is some amount of development of Brown syndrome, which kind of gets little better, but still some amount of residual Browns remains in the dextro elevation. So in the end, careful assessment and proper choice of procedure is the key to success in paralytic strabismus. Thank you.